So to proceed with our webinar, we would like to introduce our speaker. We are very honored today to have Dr. Eric Schulze, a noted medical entrepreneur, researcher, and commentator, and a subject matter expert. He is currently CEO of Lifetrack Medical Systems, a pioneer in the field of remote diagnostics, cloud-based radiology, and healthcare-related AI, or artificial intelligence. He completed his Doctor of Medicine degree and his PhD in Biochemistry Biophysics at the University of California in San Francisco. He completed his residency at the Massachusetts General Hospital, which is the teaching hospital of Harvard University. He is author and co-author of numerous peer-reviewed journal articles, as well as opinion pieces for CNN and other major media outlets. Prior to his founding Lifetrack, Dr. Schulze co-founded 24/7 Radiology, a pioneer in the offshore radiology business, which was later acquired by a New York-listed Alliance Healthcare Systems. It might also interest you to note that Dr. Schulze has been living in the Philippines for the past 14 years. Dr. Schulze, you have the floor.
My mute. Okay, hi everyone. Thanks for the introduction, Joel. Honored to speak with everyone. I'm gonna go ahead and do a share screen. Let's see, yeah, it should be more. Share, there it is, okay. And let's see, I'm gonna share this screen, okay. So does everyone see a slide? Do you see it, Joel? Okay. So let me just start the call on just talking about the COVID epidemic. And, you know, one of the things that I hope people get out of this talk is one of the issues with COVID is not so much the virus, but the fear and anxiety created by the virus. And I think a lot of that, when people start to understand more about the virus, a lot of the fear and anxiety can be at least diminished, you know, if not gotten away entirely. So there's also a lot of I'd say misinformation or misunderstanding of some of the information out there. So the first thing that I find when I've talked to people about COVID is that a lot of people don't make a distinction between who's at risk for getting the virus and then who's at risk for the different phases and levels of severity of the virus. So the first thing, we'll attack the first part, is who's at risk for getting this virus. And it turns out that this virus is new to humans. It jumped from apparently bats, but from whatever prior mammal it jumped into humans in Wuhan, China, and you know, sort of the rest is kind of history. But because this virus has not been seen by human immune systems, all 7 billion of us on the planet are at risk to be infected by the virus. But a very important distinction is that that doesn't mean that everyone's at risk for death. And in fact, depending on, you know, which study you look at and what age group you're in, this virus has a very high percentage of people who get infected by the virus can be asymptomatic. There's a recent article about a cruise ship. There, 80% of the people were asymptomatic. A lot of people know about the USS Theodore Roosevelt, which was full of 24-year-old healthy males, and it was 60% asymptomatic. And only 3 people went to the hospital, and 1 person died out of 1,000 patients. So, so most people, you know, in the younger age group will be asymptomatic. The next sort of phase is mild. Well, you'll have some mild symptoms. Then there's moderate disease where you might have experienced a bit of shortness of breath and some of the other symptoms like diarrhea and coughing and whatnot. Where it starts to get bad is the severe cases, which require being put into the ICU and then potentially getting intubated and then either making it out of that or not. So that's the final one, is death, obviously. Now, there's a fair amount of good news about this, which is in the next slide, which I'm trying to advance to. There we go. If you look at the age distribution of the fatalities in the US, and this also holds true for virtually every Western country, and we'll get into a little bit more about differences in the different country populations and demographics. But certainly for the US, and the age distribution holds true pretty much everywhere. The vast majority of people who die, who have that last phase, get intubated and die, are in the 65 and above. I mean, it's not something like only 181 deaths per million under 65. And this means that 94% of the deaths in the US were 65 years and older. And in fact, a good percentage, nearly 50%, if not more in some states, of deaths were actually in nursing homes. And so, one of the questions I ask people when I show them this slide is, have you ever wondered how a virus can determine your age, right? Does it have access to your passport? Does it have access to your driver's license? Of course not, right? A virus can't determine people's age. And you can see also by this chart that kids are almost unaffected by this virus. These numbers where you see even, where it's not zero, those are mostly kids who are immunocompromised, have severe heart disease, genetic issues, all sorts of stuff. So it's not that young people can't die, but the number of deaths amongst children is near zero. And we'll get into why it's not zero in a little bit. But so the first question is, how does a virus determine your age? Obviously, a virus can't determine your age. So the answer is it doesn't determine your age, but it does have an age distribution. It's hard to look at the first slide and say, well, wait, how is it so far skewed towards elderly if it can't determine your age? Well, this is a good example of the sort of scientific, saying of correlation does not equal causation, meaning just because there's a correlation with age and fatality from COVID doesn't mean that age causes the fatality. So one of the earliest data points that came out was, we all know Italy got hit very hard by this virus very early. It turns out that the first paper that came out looking at the statistics of everyone who died in Italy, first off, no one under 40 died as of March 17th when that paper was done. So in the peak of their crisis, they still hadn't had anyone die under 40. 88% of the deaths occurred in people above 70 and 96% over age 60. So what was the mechanism that led to this age distribution of the severe disease and fatalities? Remember the last two parts of that slide, like asymptomatic all the way to death. Well, it's only the last two that, for most of us, I think, it's only severe disease, intubation, and death that really worries us. Having a bad case of the flu type thing isn't going to, that won't kill us, is not the thing. So what is it that does it? Well, this virus causes the most severe disease in people with specific pre-existing conditions. And so those pre-existing conditions, and this was data out of New York City, where they had very good data, it turns out that hypertension, these are, comorbidities or pre-existing conditions. So this virus really has a laser target on people with the following pre-existing conditions: hypertension, obesity with a body mass index of greater than 30, diabetes, and then morbid obesity is two of the top 4 slots, body mass index over 35, and then coronary artery disease, asthma, congestive heart failure, cancer, which is really people with immune dysfunction due to chemotherapy is what the cancer is. Again, another chronic lung disease, chronic kidney disease, and organ transplant, and all the rest are pretty much just diminished immune system. So by far, these are the key comorbidities that we have to look out for. And what is the thing that ties those comorbidities together from a scientific standpoint? And so many of you would have heard that this virus has a protein on its surface that's called the spike protein, and it docks and injects the viral RNA through this dock protein using what's called the ACE2 receptor, angiotensin converting enzyme number 2, to get inside the cells. And so it turns out that hypertension, diabetes, coronary artery disease, heart disease, chronic heart, kidney, lung disease, as well as hypertension and obesity, they're all linked by having the ACE2 receptor be very heavily expressed on the outside of cells in the heart, lungs, kidneys, and vascular endothelium. So, and it turns out there's an entire literature about ACE2 receptor and obesity. So the thing that kind of from a scientific standpoint links all these comorbidities together, that is at least a hint as to why this virus and how this virus can target people with these comorbidities, is the receptor and the distribution of that receptor within the human body. But from our standpoint as human beings on the planet, the key thing is that if you do not have one of these diseases, you're at very, very low risk for getting severe COVID. Not saying you won't get COVID at all, but just that the severest form generally does not happen in someone with those comorbidities. So now I'll kind of switch into like, well, how does this virus kill you, if it will kill you? And again, it's very unlikely as long as you don't have 2 or more of those comorbidities. Turns out 80%, 88% of people who even got admitted to the hospital in New York City had 2 or more comorbidities. So if you just keep those people safe, you'll instantly eliminate 90% of hospitalizations, not just in the ICU. That's another, you have to be pretty far into it before you go to the ICU. But like 95% probably don't get to the ICU, and that 95% has 1 or 2 or more comorbidities. Anyway, so how does this virus cause death? So you can think of it in 3 phases. So the first phase is you get the infection, and the virus starts replicating inside the cells of your body, in the nasopharynx and respiratory system in general. And generally that first viremia phase, viral replication phase, is asymptomatic in everyone. So someone who never becomes symptomatic would be called asymptomatic throughout the whole disease. Someone who is asymptomatic during the viremia phase but then develops symptoms is called pre-symptomatic. It's a minor distinction, but you might have heard that phrase. If you then move on to the acute pneumonia phase, this is where the virus is actually, you can actually, by looking at CT scan or chest x-ray, you can actually start seeing ground glass opacity or hazy white opacity in the lungs. But it's also the point of time where your body's immune system starts kicking in, and you start creating first immunoglobulin M, and then in a day or 2 after that, you'll start getting IgG. So you'll have T cell and B cell activity. So that's your body's immune response is now kicking in. So the first 5 to 7 days of getting the virus and the virus replicating, that's the body's in a race against time to start the immune system acting. And so that'll be mostly the humoral immune system, but also the innate immune system, including the T and B cells. Then you'll either go into, in phase 3 is either recovery, where you have T and B cell response is adequate and your IgG and IgM kick in, and you actually cause the virus in your bloodstream to go down and then eventually 0. And that's if you're in the recovery phase. But if the T and B cell response, B cell being the IgG and IgM, is inadequate, then that's where you start to get into trouble. And the trouble isn't actually the virus so much, it's the body's response to the virus. So here in the Philippines, we all know about dengue. So we all know that if you get dengue, some people don't even know they had it. But if you get it and you feel very bad and you have the fever and your platelets start going down, you're probably going to be fine as long as you can get platelets. But there's another form of dengue called dengue shock syndrome that is really not 100% understood, but the body has been exposed to dengue before and then has a super hyperactive response to this new dengue virus, and that's when you get shocks, and multi-organ system failure. It's kind of similar in COVID, whereas it's not the pneumonia that kills you, it's the body's response to the pneumonia that will overshoot, and this is where you get into ARDS, adult respiratory distress syndrome. So these are the two curves that you might see, and I know this might be a little bit uh, uh, beyond most people's biology, but it's actually, I'll break it down, it's actually quite simple. So this thin red line is the virus nucleic acid, RNA. And you can see you get infected and it steadily rises and it peaks about 7 to 10 days. And then if you're someone who's going, someone who actually, I'll go to the bottom one, if you're going to get recovery, it's going to peak. And then what's going to happen is the T cells will initially start going down as they're attacking and dying, but then they'll start going up. And the same thing for B cells in the blood, they'll go down, but as they start getting the upper hand in the disease, they start going up. And the viral RNA starts going far down. And the inflammatory factors peak right around this 7 to 10 day period, and then they start going down. Now if that happens, you recover, you eliminate the viral RNA from you, and that's because your T and B cell system actually it was initially attacked by the virus, and that's why it starts going down. And just the fact of attacking the virus, that it uses up the T cells particularly, but then it starts going back up, and so you've won the race against time. If you're in this group where you would have those comorbidities, what happens is the viral RNA goes up and it stays up, and that's because your T cells keep going down. They don't win against the virus, and the same thing with your B cells can't keep up. And so this is where you start getting, and your inflammation goes off the charts. And it's really the inflammation that causes what radiologists say a whiteout, where the lungs are just full of fluid and you can't oxygenate the patient. So now, so is there some good news? That sounds pretty awful. So, but let me just reiterate, 95% of people won't have that, right? They're going to be the people without the comorbidities. They're going to go on and have the recovery. But even for the people with the severe disease, now that we know the mechanism of what's happening, biologists and medical doctors are starting to be able to intervene at the right time to stop the overreaction. So what do? So what they watch for is they watch for two things. Your body starts becoming clotting a lot, and so that's what leads to things like having pulmonary embolus, and that's been one of the things that people have seen increase during COVID. And then, but the more important one is the overactive inflammation. And if what you do, so there's like a protocol that doctors are starting to do in a lot of hospitals in the US. I haven't talked to doctors here yet, but where you actually follow the markers for inflammation. So they're C-reactive protein, LDH, which is a liver enzyme, troponin, and ferritin. And if those start going up and your lymphocyte count goes below 0.8 and your D-dimer, which is a coagulation, goes above 1, then you can intervene early with low-dose steroids and anticoagulation medicines. And if you do that, you can keep, and again, I don't have a full scientific paper on this yet, but the ICU docs in Louisiana and New Orleans have said this works extraordinarily well. They can keep the vast majority of patients out of the ICU, even if they're in that group that makes it to severe disease. So that's huge, hugely helpful. So what's the bottom line? The bottom line is this virus is serious for people with one or more of these comorbidities. And if we keep those people safe, we not only, we don't just flatten the curve, we cut it off at the knees. They just don't go to the hospital. They don't get infected. They don't go in the hospital. And if we keep those people out of the hospital, even the few that might slip through the cracks and go into the hospital, we can decrease the fatality rate by intervening early based on the inflammation and hypercoagulation. This is just a slide that says that yes, it's, if you have, when I give this talk, people say, oh, I've got high blood, well, if it's just one thing, you're still not in the huge percentage of people that go in the hospital. So in that New York study, they had 5,700 patients. Of all the patients, 88%. This means anyone who got admitted to the hospital, whether they were just admitted for observation all the way to ICU, 88% of them had 2 comorbidities. So again, having one, you should still be really careful. But if you have 0, you're still be careful, but you're not in the risk of the most severe disease, most likely. And then again, there's this range of severity that if you're infected, which we all can be, a large percentage of us will be asymptomatic and have mild symptoms. Some of us will go on to moderate symptoms, but pretty much only the people with 1 or 2 or more of the comorbidities will have severe symptoms. And again, those are the people who are most at risk. So that's why the key thing is to keep those people out of harm's way. But most of the rest of people, and if you look at those age distributions, because how is it that this causes that age distribution is as you age, you become larger. We all get a little bit of belly fat. So as you get older, you get obesity, hypertension, diabetes, and heart disease and kidney disease. Those things all accumulate with age. And that's what gives you that age distribution. But it turns out that if you're 70 years old and you don't have any pre-existing conditions, your fatality rate is below 1%. 1% or below. And on the Diamond Princess cruise ship, to mention another big cruise ship, the IFR, which is the number of people who died who had the disease, was 0.85, or it's actually IFR or CFR in that case. And all 6 deaths occurred in patients older than 70. So again, even though it's not age that is what the virus uses, it's the comorbidities. So all of the people who died on the Diamond Princess had 1 or more comorbidities, and they were all older than 70. So what do we do, right? Well, first off is we know the threat now. We know who's at risk. So those of us who don't have those comorbidities, we can relax a bit in the sense of we ourselves can feel comfortable that we're most likely not going to get even the severe disease or die statistically, right? And so we shouldn't panic. And then since we know who's at risk, if ourselves or someone in our household is at risk, we know that they have to be protected from getting the virus, right? And so what do? Everything that the data comes out is mask wearing is probably the most critical thing. Oop, let me go back. Mask wearing is probably the most critical thing. There are studies where they looked at transmission, and if the person who has the disease, the symptomatic person, or well, first off, let me start with one other thing. Asymptomatic people do not transmit the virus at nearly as high a rate as people who are symptomatic. So the first thing is, if you're symptomatic, stay home. Nobody gets to go into the office with a cold. So if you're symptomatic, stay home. Second thing is, if you're asymptomatic and have the disease, yes, you can spread it. But if you wear a mask and everyone else around you wears a mask, the rate of transmission is near 0. So if everyone wore a mask and everybody who was sick stayed inside, we'd probably be able to get rid of this virus even without the lockdowns. It turns out the mask wearing is that good. Enhanced distancing certainly doesn't hurt. All of the known clusters were in groups of people that were close together without masks. So, if you look about, cruise ships, big gatherings, weddings, that kind of thing, those were the places that the big clusters happened, right? Enhanced hygiene. Now this one's kind of interesting. Early on, we were all doing hand washing and alcohol and everything. It turns out, the CDC has kind of waffled a little bit on this in the US, saying, oh, yeah, you can get COVID by touching things and then touching your eyes. And then last week they said, no, it doesn't seem to, we don't see much data to support that it's transmitted that way. And then this week they said, yeah, but theoretically it can happen. And so we still think you should have enhanced hygiene in terms of cleaning surfaces and stuff. The reality of the situation is that's not the most common mode of spread. By far, it's respiratory virus. And so that means that's why the mask wearing, if I had to choose one of these things, it would be mask wearing. And then the last one is protect the vulnerable. Know who they are. It's a short list. Here's the list, right? So we made a graphic: hypertension, obesity, diabetes, chronic heart, lung, and kidney disease. And those are and immunodeficiency for any reason, or chronic liver disease. And so one thing to point out here is, and I sort of mentioned it earlier, is that it's not that kids are absolutely zero risk, but there are kids and there are young adults who have each of these diseases, either genetic, like they have genetic diabetes, in terms of chronic lung disease, if they've got bad asthma, that's a chronic lung disease. They might have congenital kidney disease. No matter what age you are, again, the virus can't tell your age. You can't say, oh, you're a young person, but you've got diabetes, I'm not going to touch you. No, it says you've got diabetes. I get people, I cause severe disease in people with diabetes. So people with diabetes, no matter what their age, people with chronic lung disease, kidney disease, no matter what their age, are at increased risk. It's just that kids in general and young adults in general don't have time to have these diseases. But if you do have one of these diseases, it doesn't really matter your age. If you have two or three of these diseases, even if you're 30 or 40, you have to be very careful. So those are the people who are at risk. And so we need to keep those people very safe, because they're the ones, who are going to cause, stress on the hospital system, and they're the ones who have much higher risk for death. So, what most employers are doing is, and we did this in our company, is to check, have our employees take a survey of of those specific comorbidities and determine if they have them or they lived with someone who has them, family or roommates with comorbidities. And for those people, work from home is a reasonable way to do it. Obviously you have to support the non-pharmaceutical interventions at work. And so masks, social distancing, and enhanced hygiene. And, the US CDC, and I think locally they've come out with, things that you need to do in your offices. But masks decrease transmission up to 80%. And if both sides have it, it gets reduced, pronounced reduction, but both parties need to wear. Social distancing and washing hands. Don't touch your eyes and mouth if you've touched other people or things, right? And one other thing that I'll tell you, it's a bit anecdotal, but it's definitive. I work with ER docs in Louisiana, out of New Orleans, and I was speaking to several of them, and they said that out of 36 people in their ER group that covers like 3 or 4 downtown New Orleans hospitals, where they were seeing hundreds and hundreds of COVID patients, and each of the ER docs has intubated more than 5 or 6 of these patients. Only 2 out of 36 got COVID, and they had been tested with both PCR testing, the rapid test, as they call them, and the serology test. Only 2 out of 36 of people who were directly exposed to people with COVID in a hot zone, in the most dangerous place in the hot zone, only 2 out of 36 got it. So, either they've got the immune system of, Superman, or yes, it's transmissible, but if you're careful, you still won't get it, even if you're in a hot zone. And of those 2 physicians, ER docs who got it, neither of their spouses got it. So by being careful, to me, that says if you're careful, you will not spread this virus, and you can keep away from it. But that's there are different levels of care, so people have to be really careful. In terms of testing at the workplace, just thought I'd mention the 2 different types of tests. There's the polymerase chain reaction PCR rapid test, reverse transcriptase PCR test, and what that tests for is the viral RNA. One thing that's come out, was, they said it early, they said it was 30% false negative. False negative means you are tested, they say you don't have it, but you actually do have it. So that's 25% false negative. That's actually a pretty high rate. It turns out it was that high rate that made people think that they had gotten reinfected, because with the 25% false negative rate, you could have 2 negative tests, and then the third one could be positive again. And so the data from Taiwan and South Korea, they looked at those patients and they found out that they are not, there is not reinfection. Number 1. Number 2, it turns out your immune response is pretty good. So you're not going to get reinfected, at least in the amount of time we've had now, 6 months. And the third thing is there are people who will test positive even 82 days out. They looked at some patients, but it turns out that the RNA the test is so sensitive if they get a good sample, that they're finding that the RNA that they can test after 10, 20 days of a few days after recovery, that's not active viral RNA. It's just RNA, but it's just bits and pieces. So that's the first part. The serology test looks at circulating immunoglobulins. And so just quickly on that, and here's where how you can see what the 2 tests. You've got a window period of about 6 to 7 days when, and this is the virus, where the PCR test will be positive for the first 6 or 7 days, while the serology tests are negative. But you won't, the funny thing is, you won't test anyone in the first 5 days because they're not they're asymptomatic. So they're pre-symptomatic or asymptomatic. So there's only about 2 days that some people are symptomatic where they'll be PCR positive, but not serology positive. Then, after about 7 days, remember there was that viremia phase, after about 7 days, then the IgM starts to become detectable. And then after that, and it's actually, I've seen other graphs where the IgG starts even earlier than 14 days, a lot earlier, like nearly the same time as the IgG. You start creating IgG. And the IgM disappears. And that's when you're in this convalescence phase where the IgG is above, you're no longer, you can't transmit. So, and it's interesting, right? Post-recovery, are people immune to infection? Short answer is yes, based on South Korea data. And if people want the slide deck, I have in the notes, it's the links to the data. But South Korea data says that they don't get reinfected. Recovered patients are not infectious, and recovered patients have primed T cell helper cells that recognize the spike protein. What this means is that not only do you have circulating IgGs, but the T cells inside your body are already primed to identify when the spike protein, when they see the spike protein. So they can start attacking even before the B cells start producing more IgG. And they also have these COVID-specific killer T cells. This was interesting. This came out, I think, either today or yesterday. But I had seen most of the hospitals in Louisiana tell people the exact same information. After you've had a positive test, so you're definitely COVID positive, you can go back to work in a hospital after your 3 days with no fever and improved symptoms and 10 days since your first symptoms appeared. And this is now the CDC guidelines. So the hospitals have been using this guideline for, like, ER doctors can go back to work even if they were tested positive. After they tested positive, as if they were 10 days past their first symptom and 3 days after their last symptom or their last fever, they could go back to work. I was actually really surprised with that. But I guarantee you, in the US, if there was any chance that they were infectious, they would not, do that. So this is pretty solid. And now the CDC says that. So that being said, what we put together sort of like a chart as to what you should do depending on if you're doing the serology tests on two different groups of people: people with comorbidities and people without comorbidities. So those without, if they're negative on IgG and IgM, then they just never been exposed, and they can still work from the home or work from work as long as they observe, NPI and all the usual issues. If they test positive for IgM, that means they're actually infected. So even though they're low risk, they shouldn't come to the office, and depending on the regulations, they should seek medical attention, and follow the protocol, in their specific municipality. If they're positive for both, that means they're in the convalescent, or getting close to the convalescent stage, but they're still active infectious. Again, they should not come into the office for certain, and they should seek medical attention, and potentially talk to the municipal health. If they're IgG positive, that means they've had the virus, they've recovered from it, they can come to the office, and you still want them to continue infection control, but they themselves are no longer at risk. So I'm hoping I'm that if I get the serology test. If you have a comorbidity, things are a little bit different. Obviously, if you have a comorbidity, but you're not IgG or IgM positive, you can still work from home and still be careful. Like, you're the ones who need to be careful. If you're positive for IgG or IgM, then you're actually infected in the active stage, and you should seek medical attention. And then, but if you've already had it, maybe you didn't even know it, and you have a comorbidity, now you can actually return to the office. So this is probably the group that is most affected. If they get a serology test and they show they're recovered, then that would be the one group that'd be safe to come back to the office. This just to give you a sense of why the numbers in the Philippines aren't like Italy. Large part of it is the median age of 25. And if you look at, deaths below 25, they're nearly non-existent. It's like, 0.01% of the deaths, some ridiculously small number. So where 50% of our population is 25 or below and 50% is above, and only in the Philippines, only 4% of the population is over 65, you can see that we're really mostly dealing with this part of the curve. So that's in large part why probably the virus case numbers, because you don't test people with the PCR test unless they are symptomatic. That's, it's a selection bias. So the case numbers don't actually tell you how many people have been infected, but they do tell you how many people think they've been infected and wanted to get tested. The demographics, again, you can see this is the classic, demographic pyramid. And so we're talking about just the last, just here, right? So, and I'll just say a quick thing about CFR versus IFR. Case fatality rate is confirmed cases. In this epidemic, almost all across the world, and certainly early on everywhere, this was the confirmed cases were based on the PCR. It had 30% false negative, but more importantly, the only people who were tested positive were people who were generally symptomatic and went to some place to get tested based on, hey, I don't feel good. Do you think I might have COVID? IFR is a very different number. It's based on all the people who had infected, how many people die. And that's generally determined pretty far into an epidemic. And so most times that number is 10 to 100 times lower than what the CFR generally says. And I think maybe the next slide. You know, I won't go into this too much. It's the confirmed cases. But if you look at, you know, New York hospital admissions and Italian fatality, most all of the severe disease is seen in people with those comorbidities, you know, those non-communicable diseases, you know, and they were all, you know, in Italy, they were, vast majority were above 80 even. So this was sort of the final, you know, thing of what you could do is just like stagger, you know, age, let people out based on age. I know that they've done it a little bit differently here. This was something that we developed for our article in CNN. And I think that's a good place to stop because I'm sure people have questions. So why don't I stop there? And here's my email in case people want to contact. And I think, yeah, okay, 45 minutes. I've
Thank you for that very informative talk, Dr. Schulze. We have some questions. The first one is the number of comorbidities would be a stronger predictor of possible serious effects from the infection rather than age or age risk. Would you agree with this?
Yes, absolutely. I mean, that's the really critical point. Whoever said that, you nailed it. I mean, it turns out that in this disease, and it's very different from a flu. A flu targets a cell receptor that's on every cell, and that's why it kills people at both ends of the age spectrum based on diminished immunity, and anyone in between who has poor immunity. That's what the general seasonal flu does. Whereas this thing has that crazy, you know, super old age risk, but it, like you pointed out, it's not the age, it's the comorbidities. So that allows us in this disease, unlike the flu, to really be specific in targeting who we safeguard in our populations, in our homes even, right? You know, I mean, as a parent, as soon as I saw this thing has like near zero fatality for kids, I was like, okay, I'm done. You know, if it gets me, that's one thing. If it gets my kids, I mean, if it showed the opposite, I guarantee you we'd all have our kids in the back room with the door shut and cut out a little hole to pass food, right? I mean, you know, so yes, it's definitely the comorbidities, and we want to make sure that we kind of do the same thing for our elderly parents and our, you know, titas and titos who we know have the, you know, comorbidities. Those are the people to safeguard. So yes.
Comorbidity is a condition. What if it's under control and you're taking medication? Will that aggravate the situation?
Oh, it's a really good point. High level answer is we don't know yet. But this question usually is related to antihypertensives.
Yes.
So early on, there were some reports of, oh my gosh, if you're on an antihypertensive, and there's two main categories, ACE inhibitor and an angiotensin enzyme blocker, you know, an ARB or an ACE inhibitor, right? And so early on, they thought, based on the fact that this virus targets the ACE2 receptor, and when you take either of these drugs, your ACE2 receptor, your body kind of reacts to the those ACE inhibitor and ACE receptor blocker by upregulating the number of ACE receptors. So everyone thought, oh my gosh, you know, if you take those meds, you're going to have a lot of ACE2 receptors and you might be at higher risk. But pretty early on, the cardiovascular doc said, we don't think that's happening, but, you know, it deserves more, you know, understanding and more data, but people should stay on their ACE inhibitors and ACE receptor blockers if they're hypertensives. It then later on, you know, that we've learned so much in biology about this, but later on it came out that no, you definitely should stay on the ACE receptor blockers and the ACE inhibitors, and they were both actually somewhat protective. Now, we don't know if that takes you out of that comorbidity category yet. That data hasn't come out yet. I've been looking for that, and it's a critical question because obviously, you know, hypertension is one of the highest prevalence, comorbidities. So if we can take that off the board, right, take it away from COVID, then that would be a huge help. Right now, we don't know yet. We do know that you should stay on your
Okay.
ACE inhibitor and ACE blocker because it doesn't increase your risk for severe disease. So you're
Okay.
at, so you should definitely continue all your medications. And in general, that's probably the best advice for most times. Stay on your meds. But in this case, they actually looked very closely at those particular medications because of hypertension being one of the top one. Yeah.
Okay, thank you. There's another question. Hello, Dr. Schulze. May I ask if there is a confirmed study that COVID is airborne or not? Can it be transmitted through the air conditioning system? Thank you.
You know, I don't think there's I mean, there might be some theoretical papers and there might be some, sort of like testing that they did on droplets. They can see them, moving through. The data that would tend to make it seem that it could, you might extrapolate, out of 5,000 crew members on the USS Theodore Roosevelt, aircraft carrier, 1,000 of them got it. Maybe that has to do with them being in close quarters when they eat together. There's no way, we don't know yet is the big answer. It's, so I wouldn't say yes or no yet. We don't know. There hasn't been a definitive, I don't think I've seen a report of a cluster of cases yet where they said the only way these people in this room could have gotten it was if it came through the AC. I do know that the CDC, does talk about, increasing the amount of outside air that you bring into your office spaces. And so, on most of the control units in the offices, there's a button you can press that says bring in fresh air. The Daiichi buildings are all LEED certified, so they're super green. That means there's not a lot of air exchange unless you press that button. Yeah.
Plus we do the VRV system, so air is not actually shared across office units. It's
Oh,
just
okay, good.
within your unit.
Yeah. Okay, so that's key. And again, I mean, it's a good point, Joel, because the reality is nobody should be going out if they're sick. That's like rule number one. Do not go out. Like, I don't care if you think it's a cold. Don't go out. I mean,
Yes.
First off, like if someone sees you hacking and coughing, you may be under bodily harm. But second off, it's just a good idea. Stay home. You're used to working from home. You got a cold, stay home and have the cold. But obviously COVID is the same thing. So you should definitely stay home. But that's a very good point. They're not actually, the offices aren't linked. So if you take care of your people, you should be fine.
You mentioned about the importance of masks. What type of mask would be best?
Yeah, I mean, there was there's a big thing about the N95 mask. That's what they used inside most hospitals. But that's really when they're, going in the room with a COVID patient or they're in the ER where they have to assume everyone's got it. I think, again, when they did those studies about masks, I don't know if it was the N95 or just standard, surgical masks. For the most part, it's a matter of percentages. So any mask is better than none, and if both people have even just the surgical masks, the rates are far, far diminished. So
I've heard on CNN even homemade masks from handkerchiefs would be just okay.
Yeah. No, because I mean, if you look at the respiratory droplets, one thing, I guess, one sort of thing I try and tell people, it's like, look, this virus isn't magical. It doesn't go through walls. It doesn't quantum tunnel. It's a biological phenomenon, and it has a physical presence. So if you stop, if you increase the defenses for for it getting out, you can definitely decrease its risk of spread.
Okay, thank you. There's another question. Thanks for the great informative talk, talk, Doctor.
Thanks.
Super helpful. Question is, where can people get the serology test kits? Is it like a pregnancy test that people can administer on their own, or it has to be administered by someone medically trained?
Yeah. So the
And sorry,
serology test.
how
Yeah.
much? And sorry, how much?
Okay. The how much I'm not sure, but I think that they're anywhere between 600 to 900 peso. Um, but if you are not a medical doctor or you can't get it through your employer, then you would go to like a family doc or a My Health or whatever, and they would be able to administer it. In terms of what the test is, it's actually very similar to a pregnancy test in that you put a drop of blood into a well, and then you add sort of like a diluent, a dilution, but that basically helps move the fluid, including the blood, through a path of a particular type of uh, I don't know what you call it, like a sponge kind of thing. And then depending on if you have IgG or IgM, just like a pregnancy test, you'll have 3 bars, not like, I guess it's not AB. So don't look at it and go, oh my God, I'm pregnant. So what you'll see is 1 bar will be IgG, 1 bar will be IgM, and the third will be control. So you should always see the control bar. That just says, okay, the lateral assay worked. IgG, is the good one that you want to see. If you see that alone, then you're kind of like, you had it, you're done, you're good. If you see IgG and IgM, then that means you're currently under
that's
active.
that's what's popularly known as rapid tests, right?
Well, yeah, it's
Is
kind of
it?
funny because the rapid tests, I've heard people refer to the RT as rapid test, but it's actually reverse transcriptase PCR. And see, the thing is, the PCR tests, when they first came out, remember, it took a week to get the result back because they
Yes.
had to send them to one hospital. They were the
And
ones.
that's the swabbing, right?
That's the swab. But
Yes.
now they have swab tests that are pretty rapid, like 15 minutes an hour. So I've heard some people call those rapid tests because they're more rapid than the weak. But but that's why I really say PCR versus serology. You know, my guess is, I mean, the serology ones are like 15 minutes. You
Yes.
know, so it is in general much more rapid. There are PCR tests now that are around 15 minutes, but I
Oh,
don't know if we have them here.
okay.
So probably when they're saying rapid test, they probably mean the the serology tests. But like
Yes.
I say, some people misinterpret the RT in front of
Okay.
PCR for rapid test. It's actually reverse transcriptase. But so
That's why I think here they use just the term PCR
yeah,
rather
it's
than
it's much better to say,
RT-PCR.
yeah, PCR serology. and
Yes.
and I'm tending at, now that we're sort of pretty far into the epidemic, I'm tending to say, since the serology misses just a few days after symptoms present, you you're going to get pretty nearly, you might miss those first 2 days of symptomatic. So but most people are not symptomatic, and particularly if they're coming back to work, you may want to give a test that will tell where you stand amongst your employees. And so the serology test is probably more useful for, and certainly for peace of mind. If someone is IgG only positive, then it's like, they're past it, and they can say, oh yeah, I remember 2 months ago at the
And
beginning of lockdown, my kid came home, sniffling, and yeah, I
I
must have
guess
gotten it.
I guess it's also so much better if the results will be interpreted by a medically trained person.
Yeah, and yeah, I forgot to answer that part. Yes, so you should, in general, you can, most of the PCR, or I'm sorry, most of the serology tests you can get with a drop of blood from a finger stick. Those are the easiest to administer, but even so, you usually would have them administered by a nurse, you know, and then interpreted by a trained nurse or a physician who, knows, because even though it's like 1, 2, or 3, it seems pretty obvious, 1, 2, or 3 lines, sometimes there can be faint positives. Those are actually positive. So it should be done by someone who's been trained in interpreting the tests.
Okay, thank you. Another question, even if we are not in the high-risk group, no comorbidities, we can still transmit the virus to our loved ones who have comorbidities, right?
Yeah.
So we should not visit our parents and grandparents until there is a vaccine that are injected with. Is this the right thing to do now?
Yeah, I mean, so it's along the right lines in the sense of like, yeah, those, anyone who, if you yourself don't have a comorbidity, you can, if you have, like I said, the first thing was everyone is at risk for infection. That means that everyone's at risk for spreading the infection, right? And because oftentimes, particularly if you don't have the comorbidities, you can be very frequently asymptomatic. And so in fact, that's how most of the nursing homes had the high fatalities in the US. It wasn't, people in the nursing home, because where would they get it from? It was the employees who went home, got it from their kids or from someone else, or went out, and to a movie or whatever. They got infected. They went to work, and then once it got into that environment, then it spreads like wildfire, because people are super symptomatic because they've got so many comorbidities. That's why they're in the nursing home.
Okay.
So yeah, you should definitely make sure not to go to Lola's house until you can be certain that they're safe. And yeah, we definitely, I mean, everything, I'm optimistic, and so yes, by the end of the year we hope to have a vaccine. It's not that, I mean, you see pictures of people going, and standing outside and at least waving, so you could, and like I said, the fact that, I mean, someone asked me in another presentation, look, I have 3 of those, but I still have to go out shopping. And what I said to them is like, look, again, it's not magical virus. As long as you mask appropriately, and those people I'd say use the N95, as long as you mask appropriately. And for those people, I would say wear some sort of form of eye, protection, more so you don't touch your own eyes. I mean, like I can't touch my eyes because I got my glasses on, so it reminds me. So if you have those comorbidities, you should be super careful. So you could go visit them, but like none of us wants to harm our grandparents. So yeah, I wouldn't argue against saying, doing Skype until there's a vaccine or a treatment. The other way out is that there's, like I was saying, once, if we find out that they can short circuit the inflammation response that's responsible for the vast majority of deaths with COVID, then, so treatment or vaccine, either one of those things, as long as those come about, then it becomes, much more reasonable to say, okay, now you can visit.
There are still a lot of questions, so
Yeah.
let's get right to
Yeah,
them.
sorry.
Another one is, how reliable are the PCR tests offered in the Philippines? Would you recommend several tests to increase the reliability of the results?
Well, I mean, so the reliability, of the worst. I read an article where they actually had 2 groups of, scientists look at the reliability and sensitivity and specificity is how we look at it in science. Sensitivity is if you're positive, how often is it positive versus not. So if it's 99% sensitive, that means that it's positive for 99% of the people whose blood we know was positive because we know they had it, right? So most of the tests were in that 99, 95 to 99. There were some that were 16% non-sensitive. And so, but compare that to 25%, I think in general, the serology tests, at least if you look at the numbers, are better, right? And
Okay.
because the other thing to think about is the PCR tests are generally positive while you're actually have virus in you. And that falls off after, we see people can go back to work 3 days after their last fever and symptom, right? So if you think about it, we're now 5 months into this thing. If you can only look at 2 weeks versus you can look at 6 months, right? Because your IgG is a history, right? You'll know whether you've ever been positive. The PCR test only looks for that one short window. Yeah, it's a snapshot. So at this stage in the epidemic, I sort of tend to think that with the higher sensitivity and specificity of the serology and the fact that it can tell you the past, not just the present, I tend to think the serology ones are more useful that way.
What are your thoughts on mass testing?
I mean, the problem with mass testing, as soon as Fauci, like this was way back in probably January or February, as soon as they said this thing spreads from asymptomatic people, it's like, okay, the cat's out of the bag and there's no getting it back in. Once you have asymptomatic spread of a virus, you can't really contact trace, right? Because you could have 2 or 3 asymptomatics between 2 symptomatics. Well, how do you trace that? Like this guy was in Italy and he was asymptomatic, and then he came to the Philippines, and that guy he in fact was asymptomatic, and that guy went to Singapore who was asymptomatic, but then he gave it to someone who was symptomatic. You're never gonna, well, where did he get it from? How could you know? Because it was 2 countries and 3 weeks prior that there was any, and there were like thousands of people who that guy got. And so I think testing and tracing your way out of it, I can't see how that can work with such a high, and again, the Philippines is very different from the US. If you've got a 25-year-old population median, there's tons of it. It's like the USS Theodore Roosevelt, 1,000 people, 60% of them are asymptomatic and spreading it. Right? How is that possible to test and trace, and they're only positive for like a week, so that's the, just from a, epidemiology standpoint, it's hard for me to imagine at this, and particularly now 6 months into it, right? And I know there's that company ARC, the NGO, that's doing serology testing. They went to Tondo. I mean, I thought the number would be a lot higher, but they found 8% seropositive. That's a huge number, in terms of like how many people that would be. There's no way you could then go to Tondo and contact trace 8% of probably 1 million people, right?
Yeah, that's true. Another related question about asymptomatic people. Do you think companies should test asymptomatic employees?
Yeah, it's a really good question. I mean, just based on looking at what the CDC said of when you can go back to work, I mean, it's almost, it's hard for me to imagine how that's going to work. Like you'd have to test them every week or 2 to be able to confirm that nobody's ever positive, right? So, I mean, doing PCR testing on huge numbers of people, like, like they have a watch or a band. Okay, it's been 2 weeks since my last test. Okay, we're gonna do the the nostril thing again. It seems like that would be a really hard thing. And what are you going to do about it, right? If they're asymptomatic, their chance of spreading is super low, and they're going to be masking. And like if you said, okay, we'll let you come in and you don't have to mask or anything because you're negative, well, but even then it's 30% false negative, 25%, right? So I can't see that giving anyone real certainty, right? I mean, you can't be certain. Even if you had a negative PCR test, it might have been one of those 25% false negatives. And so then you let them into the room. Well, what are you going to do when they get in the room? Well, they're still going to have to be masked and do all of the, I mean, all of the guidelines I've seen, and I'm sure, the ones that you put out in Daiichi is the same. It's like you still have to do everything, right? All the, the social distancing, hygiene, the and masking. So yeah, I mean, I've heard people talk about that. I just don't see it giving anyone, or if they know the reality of 25% false negative, I don't see that that gives people a real sense of real security. They give you a
Okay,
sense of security, but not, not actual real.
not significant.
Yeah,
Okay.
yeah.
Before we proceed to some other asymptomatic questions, or questions about asymptomatic people. There's this one question from a medical standpoint: is there validity that having flu vaccines can minimize the severity of the COVID-19 infection? That's a question.
I haven't seen any data on flu vaccines. The one bit of data that is interesting, and again, it's more of a correlation, that I've seen. I haven't seen actual studies. Is that in the countries where there's been BCG vaccine, right? That you get for here in the Philippines, but all throughout Africa, most of Southeast Asia, you get BCG vaccine as a kid, which is to stop TB. It increases your innate immune system. And
Uh,
so in those countries where BCG was used and is used all the time as part of the childhood vaccinations, there's less COVID. Now, is that because they're also frequently hot countries? I mean, we don't know, but there is a correlation between BCG and diminished,
but
amount of COVID.
but COVID is not a flu, right? It's a
It's not, yeah,
pneumonia
exactly.
kind of
COVID,
illness.
yeah, COVID is, I mean, so at a virology level, they're very different bugs in the sense of COVID specifically targets this ACE2 receptor. The most of the flu viruses target like a glycoprotein that's on most all cells, and so this thing really it's very different. And so now that being said, obviously it's not TB either, but this BCG vaccine is one of the ways that it acts to diminish a lot of people have found that flu is less in places that have BCG, for instance. Well, it's because at least the postulation is it's because the immune system is more robust if you've had the BCG vaccine. But
Okay.
as far as I know, there's no real specific, they don't have the data yet that says if you have a flu vaccine, you won't, or you have a decreased, likelihood of this. Maybe
Okay.
true, but we don't know.
There's another question on symptomatics. What is the mortality rate of asymptomatic individuals with
Yeah,
COVID-19?
it's a very good question. I haven't seen a specific, because again, I've seen age-related IFRs, infected fatality rates, and for kids they're like 0.0006%, like vanishingly rare. I haven't seen that, in that specific issue. But what I can say is, if 99% of the people who died had the comorbidities, and let's say 90% of the people who get admitted to a hospital have one of those comorbidities, that means that only 10% didn't. And so if that means that only 10% without a comorbidity get to the hospital, that's at most the number of people who might have died, right, is that 10%. That means that the IFR would be 10x less, and the current IFR that like the Center for Evidence-Based Medicine is talking about is something like 0.1%,
So
like
very
1 out of
little.
1,000. So this is like, we're talking now 1 out of 10,000 level, which is below sort of seasonal flu levels. My guess is it's actually even lower than that, because they're using almost all Western countries, which, something like 20% of the population in some like Italy, where the median age is 45, something like 20% of the population is above 65. So you've got the IFR is going to be much higher in those countries than in countries like the Philippines, where only 3% is above. So
Okay, another question. Thank you. Is it true that there are long-term effects once you catch the COVID-19? Even if
yeah,
you're asymptomatic, would this have any effect on the body at a later time?
yeah, great question. So the only studies I've seen about the long-term awful structural effects in your lungs, they've all been studies on people who had been intubated. So, like, but those same studies are done with people. Anyone who's been intubated has potential structural changes to their lungs. I
Yeah.
have not seen a single
Oh,
data point or article written about people who are asymptomatic, mildly symptomatic, or even moderately symptomatic to look at, and I would know this, to look at radiological changes. For instance, if you obviously not going to do a biopsy, or a autopsy on someone who's alive. But so, the only things that we could look at, there's not been a single study about recovered asymptomatic or mildly or even moderately symptomatic people to look at their lungs. So,
but for those intubated, they really have permanent lung damage.
it's a funny thing. Permanent is, I don't, the only way you could say that is if we were 2 years out.
Okay.
Because the body actually has a pretty good chance of healing. Now, if you're 80 and you already have COPD, then yeah, almost certainly you would have long-term structural damage. But that's kind of the point. Most of the people who get into that, they may have already had something to start with. And if, like, the whole point of treatment and everything now should be keep those people out of the hospital, keep those people, at-risk people, from even getting infected. And if they do get infected, cut it off at the pass before it gets inflamed, get the overinflammation.
Okay, thank you. Another question. Companies may focus much effort on alcohol, hand washing, sanitizing of common areas, elevators and work areas, etc. Do you recommend companies to instead invest in systems to catch, control, manage symptomatic people or employees, ensure people to wear masks in an office to make the office working environment safe?
Yeah. Yes.
That's a long question, but it's a
but no,
short
it's
answer.
I totally, yes. I mean, here's the funny thing. This is a personal anecdote. I went to Starbucks and they told me to use the stuff, and I'm like, my hands are raw from the alcohol. I said, look, I'm allergic. I don't want to do that. And it's a contactless, like, I don't touch anything in there. I'm the only one who touches my card that goes through the thing, right? And then they're the ones who hand me the cup, which I take out. I haven't touched them or anything in the whole, like, they opened the door for me. So yes, at some point, common sense has to take over. There's no need, like, one of the things I saw, is like, clean the typewriter pad that people use on their computer. Well, if you have your own typewriter, you're the only, like, I don't go around putting my fingers on other people's keyboard. I don't know anyone who would, particularly now. So yeah, I think the key thing is
Unless you're
the number
sleeping.
one. Yeah, not exactly. If you're, oh, what are they doing? But number one is, yeah, anyone who's symptomatic, please don't come in. Like, so we don't want people symptomatic to come in under any circumstances, even if they sneeze in the morning,
Okay.
just stay home.
I
Yeah,
think there are a lot more questions.
yeah.
So
Sorry.
I know we want to hear more from you, but if you can keep it a little short.
Mm,
So
I'm sorry.
yes,
Yes.
sorry,
Yes. The
sorry
answer is
for
yes.
that. This is a question that's coming from somebody who has some medical training. It says here, coronavirus and retrovirus are both RNA. I don't know what RNA means. Some hospitals used retrovir as treatment for the COVID-19 recovered patients early in March. Is there a study that it really treats COVID-19?
Yeah. So there are, I mean, yeah, I got to keep this short. So it's an RNA virus. It uses a reverse transcriptase, and but it's different from most of the retroviruses. So the answer is, the only way to tell whether a drug works is to actually do the controlled, studies where you do case control, and and to my knowledge, the only drug so far that has shown under the most rigorous types of testing that it works is that remdesivir. There's a lot of controversy about chloroquine, and there are good reasons to think it might work early in the disease course, but definitely not later. After the horses left the barn, a lot of drugs won't work. So yeah, I don't know. I think it's ritonavir is the one that they're probably talking about. I don't think it's been shown to be useful against coronavirus in a case-controlled study.
Okay, another question. How about using UV lights and using HEPA air filters in the office? Do you think these are effective in controlling the virus in the workplace?
Yeah, I mean, I don't think, I don't think you can argue against using a HEPA filter. I think ultraviolet, it definitely, there are studies that show that ultraviolet does deactivate the virus. Again, the theory would be if you had someone who was infectious in the office, then those things would be really important. Like if and so since we can have asymptomatics, it's possible. But then again, that's where I sort of tend to say, well, if the mask works, if both parties have it regardless, then I think that's the key point to make it. And that's, the CDC is pretty much saying, like, as long as you do that part of it, the rest of it is less important. That's, again, and that kind of points out why the testing part is probably not going to get you there, because you're still going to do the thing that will stop it anyway.
Okay. Another question, do you highly recommend eyewear when going to dense places? They say the virus can enter the eye region.
Yeah.
That's a question.
It's, again, this is where, down the line we'll have probably better studies. For the most part, the standard way that people think that it gets into your eyes is because you touch something that was in, like a surface. Now, surfaces are now less likely, apparently, to do this, but so you shouldn't touch your eyes or nose or mouth, any mucous membrane with your fingers if you've touched a surface, is really the answer to that. Anything that stops you from touching your eye, like a face shield, it's much harder to get to your eye with your face shield on. I tend to think, I don't think, and I haven't seen any reports of someone saying, oh, this guy sneezed over there and I got it through the air. One of those droplets hit my eye and then got me infected.
Okay.
Theoretically, it's possible, but that hasn't been proved as a way of transmission. Whereas the touching is more, I don't know if it's been proved either, but it's more likely. That's the more common way people think of it.
Okay, another interesting but short question. Is it okay to exercise like to jog while wearing a mask?
Yeah, I mean, it's kind of funny. There's not, I mean, where they've looked at clusters, they've never found a single cluster that was based on the jogger infected 7 people along his path, right? It's only in those enclosed spaces that you get, the infection. I know we've all seen like videos of some Japanese guys, sneezing and infecting a whole room, by micro droplets and lasers. I don't know if anyone's seen those. They're disgusting. But there's theoretically, there are droplets that come out while you're jogging, but like it's highly unlikely that you're going to be spreading it while jogging. That being said, I think right now we're supposed to mask anytime we're out in common areas. So it's kind of, the answer may be no, but the reality is that based on, the GCQ or the MECQ, whichever regime we're under, you're still supposed to wear the mask outside. And it's, probably the wise way to go. I've seen people jogging, they are safe, but could they spread it? Yeah, but it's pretty windy So it's the thing that people don't take into account is just the ability for like the things diffuse really rapidly. So
Okay.
out in open air, it's unlikely.
Okay, thank you. Another question. IgG seems to be used as an indicator for having had the infection. Is this a safe assumption to make? Are there studies which correlate IgG levels with residual viral load?
Yeah, so the IgG studies I've seen, well, there's two answers. One is that you don't survive the virus if your immune system didn't kick in and get rid of it. So that's number one. I mean, that's true with any virus, well, except for the ones that hide out in your DNA, like the
Okay,
retroviruses. But this one doesn't do that. So the IgG levels, like if you recover, you definitely have IgG levels, and they've gone out pretty far now, 2, 3, 4 months now, and they see that they stay high. Even if your IgG levels drop, there are these things called memory B cells that know how to make that IgG, and so if they get exposed to that protein again, they'll start making it again. But we don't know that yet, and we don't know how long the immunity lasts. What we do know is that for SARS, the original one, the immunity was 2 to 3 years, and while they had circulating IgG, and this SARS-CoV-2 is most closely related to SARS. So that's the best guess as to that this
how long?
IgG, yeah,
Okay,
will probably, at least you'll have circulating IgG out to 2 years, probably, maybe even 3. But even when your IgG falls off, it doesn't mean that your immune system isn't primed against the virus. It means it may take a little bit longer, but it generally means you're safe from it. And
here,
MERS was about a year.
okay. Here's a related question. What about if we are immune, having recovered from a previous infection? Can we still transmit the virus to our lolo and lola?
Yeah, no, that's I think the key point of that CDC recommendation, that if you're even just 3 days past your last symptom, you can actually go back to work in a hospital. And that's all the hospitals that I get their circulars as to back to work policy. It's like 10 days from your first symptom and at least 3 days after your last symptom. So if you have waited at least that much time after your last symptom, you're probably safe. And if you have IgG, you would be past that even. If you only have IgG and not IgM, that would be in the convalescent stage. So
Okay.
yeah, if you're IgG positive only, not IgG and IgM, then you should be past it. I mean, if you're only if you had the test, you're only IgG, but you're 2 days since your last symptom, wait a week.
Okay.
Don't
Thank
rush.
you. That answer, that response from you answered 3 questions actually.
Oh, good.
So we're cutting down on the questions now.
Good.
There's this question. They say that heat kills the virus. So will this rainy season be a factor in spreading the virus? Is the first statement true at all?
Yeah, I mean, there were some statistics. The last paper I read about it was kind of a statistics argument, which is kind of one of the maybe kind of things, that heat probably does decrease the transmissibility of this virus. Some people have made a distinction between dry heat and wet heat. So, but this is where you start talking about percentage and likelihood. So statistically, overall, heat probably does decrease transmissibility, but on an individual level, it can't change your behavior. You still have to mask and do hygiene.
It's sorry, it's already
I know.
3:30.
Oh wow.
But we're up until 3:45,
Oh,
so
okay.
there's still room for a few more questions. And this question is a little, I know, will require a lot of discussion from you. Can you clarify the concept of herd immunity?
Oh
Is it
yeah.
something you recommend
Okay.
to address the virus?
Yeah, so let me explain herd immunity, at least as to, you know, sort of a simple explanation. So people may have heard of this number called R naught, which is, you know, the basically how many people on average will one infected person infect. And so the R naught for COVID or SARS-CoV-2 is something around 2 to 3 is the number that I've seen most common, some 2.3, 2.5, something like that, which means that if I have the virus, I will on average infect 2.5 people. You know, somewhere around 2.5 people will get infected by everyone who gets infected. So if every single person who gets the infection infects 2 people, then it does, you know, it multiplies logarithmically, right? I mean, it doubles, you know, every person who get it doubles it. Now, um, um, herd immunity is kind of like where you look at an effective R naught, which means that let's say I have the virus and 50% of the people in the population have already had the virus, then on average, I'm going to infect 2 people, but one of them's already been infected. So my effective rate of transmission is just 1 to 1, right? And if, let's say, there are 3 people, you know, that it was that I've that out of 3 people, let's say 66% of people have had the virus, then out of 3 people, I might only infect 1/3, right? So as one person can only infect, you know, 1 out of 3 people, then the virus would die out because each person can't transmit it to more than one person, right? So that's kind of the idea behind herd immunity, is that if you have enough percentage of the population has already had the infection, then any one person will be likely to spread it to people who've already had it, which means they won't spread it.
Either naturally immune or through a vaccine, right?
Yeah, exactly. So, so the long-term idea of vaccine or herd immunity is that you basically increase the effective number of people who have IgG and can't be infected. So it will then kind of die out just
Okay.
naturally. Now, what's very interesting to me is that, like, even in places like Sweden, where they never locked down and they basically said, well, we're going to kind of just do the standard playbook of epidemiology, which is you basically quarantine only people who are sick. And most of the rest of the people, I mean, I know Sweden's gotten a bad name, but most of the rest of the people did do social distancing to some extent and masking to some extent. So they were much more careful. They weren't partying out like it's 1999, but they were not locked down, right? So but what was interesting to me is when they looked at the actual numbers, even in Stockholm, which is a city, you know, so, and there's mass transport, I think, there, and they only found, at least the last time they looked, which was maybe about a month ago, only 20% of the people had had it. So to me, what's interesting is that I think and the fact that Tondo only had 8%, if that's true, it's actually surprising to me, and I don't think this virus is as transmissible as I think the original models had
Thinking.
predicted. So,
Okay.
you know, whether we hit herd immunity, it doesn't look like we're very far along that path, but we're not seeing ungodly numbers, you know, and it was always surprising to me that, you know, the Philippines, which had the first death outside of China, wasn't hit harder, because we had people coming from China right
Yeah.
after Chinese New Year. So I couldn't really, when I looked at the numbers, even though I knew testing wasn't that much, I still couldn't make any sense of those numbers if this thing was as transmissible as it was supposed to be. So that was actually one of the things that got me kind of wondering. And if you look at the map of the world map, and you look at median age, it's almost like you could plaster it on that John Hopkins map, because all throughout Africa, there's like tiny numbers. And I've been in touch with people who sell our software in Nigeria. The numbers are really low, and even though they went on lockdown, it's very much like they're much of their population still went out shopping in the wet markets, in the open air markets and stuff like. They didn't have the wet markets like China, but they had open air markets, kind of like we do in places here. And I mean, the numbers were not that much. Now, does that mean that the number of infecteds wasn't that much, or it's just the number of symptomatics? Because the median age in Nigeria is 18. 50% of the population is below 18. So to me, it was, I still don't know the answer because we don't have the serology. That's the only way we'll know. Did they have it, but they just weren't symptomatic because they're 50% of them are under 18? So that'll be the, as time goes on, those are going to be the interesting numbers. But I also think that this virus, it may come out that this virus isn't as infectious as we thought, which would be great. I mean, so far the news that now is starting to come out has been relatively good,
Okay, thank you. There are a few more questions, but they're related to the ones that were answered earlier.
Oh, okay.
Just one last question that's a little bit interesting in a different sort of way. The question is, are there studies that confirm that the coronavirus is not a virus, but a bacteria that causes death? It
No.
causes blood clots to form and causes the death of patients. COVID-19 is nothing other than disseminated
Oh,
intravascular coagulation. Is
yeah.
this a
So
theory?
no, so this is one of those things that contains elements of truth, and it's an interesting question. So, and I'll probably go too much into the biology, but probably the person answering it has more biological knowledge. So the fact is that this virus targets the ACE2 receptor. Well, one of the places that has a lot of ACE2 that this ACE2 receptor is on, remember, hypertension, the ACE2 receptor is related to the body's mechanism of controlling your blood pressure, right, within a certain range, 120/80. That's where you want it to be, right? And so one of the ACE2, one of the places in the body that has all the ACE2 receptor that's highly expressed is the vascular endothelium, and that's because one of the ways the body controls your blood pressure is by contracting the vessels or expanding them, right? So there's a lot of ACE2 receptor expressed on the vascular endothelium, the lining of the blood vessels. And so it turns out that this virus targets those cells. Well, when those cells get infected and die, there's inflammation. And inflammation in in the vascular endothelium is a common pathway towards atherosclerosis. You get inflammation, you get increased blood clot, all those things. So there is a mechanism by which that cascade appears to happen in this disease, COVID, in the people who have that overactive inflammatory response. And so that's why one of those inflammation markers that they watch is coagulation, is a coagulation marker, a D-dimer marker, saying, oh no, this person's starting to have hypercoagulability. And so that's why they're starting to give people early on either heparin, which is a blood thinner. If they're in that moderate to severe group, they start anticoagulating to block that piece of the puzzle so that you won't go into DIC, because DIC is like very far past, like once you've started coagulation everywhere, you actually use up all your factors, and then you can't, so that is a mechanism. It pretty much only happens in the people who are on the severe, to the fatal side of things. And they've looked at that by doing autopsies. So yes, that is a final common pathway for how this triggers the really bad side of COVID. But it doesn't support that there's anything like, it's still a virus that did that. It's
Not a
not
bacteria.
not a bacteria.
Yes.
Yeah. You can get secondary infection if you've got a pneumonia. You can get secondary infection. That's why people treat with azithromycin or some of those other things, so you don't get the secondary infection. But it appears to be the over-inflammatory reaction, actually not secondary bacterial infection, that causes the severe ARDS. And so that's purely based on the virus and the immune response.
Okay, I do not understand what you were saying. I just took biology 11 in
There you
college.
go.
So anyway, you've answered most of the questions. There are still a few questions that will probably go to your email, and
Yeah,
you've
that's fine.
flashed your email address already
Yes.
earlier. Um, Before we end the webinars, there's some final words that you want to say, Dr. Schulze?
Yeah, no, I'm hoping, I hope I didn't scare anyone. In fact, I wanted to do the opposite. I mean, the news from this virus is that if we help protect, the vulnerable, and we ourselves practice standard, masking and social distancing, we can pretty much defeat this thing and get back to work, and so, that's the final sort of, analysis is that, and we will make, I think, coming out of this, just like before HIV, there was no such thing as a retroviral drug. Now we have a whole huge number of them, and there are a lot of trials with that. So after this virus, the good news out of this virus will be we will find out a lot about the biology of obesity, hypertension, diabetes, all those things, and we'll also find out a critical bit of information, which is how to stop that overactive inflammation. So very likely, if there is another pandemic, the response and the understanding coming out of this pandemic will be hugely useful for the next one. God forbid there is a next one, but like if there is, this is going to be, it's kind of like, I call this like a shot across the bow. It's not nearly as deadly as initially we thought it is. And that's another piece of the information that, I hope, even if you thought it was age related, like it's pretty heavily skewed towards elderly, but based on the comorbidities. So it's not, it's not as scary. And even if you have one of the comorbidities, it just means you have to be very careful. So
You've certainly achieved your objective. You've
well,
reassured us.
well,
Thank you
thank you.
very much.
All right.
Thank you for sharing your expertise and your fantastic analysis of the virus and the COVID-19.
Well, thank you.
And thank you very much, Dr. Schulze. We also appreciate everyone for attending and tuning in. We hope you were able to take away new knowledge about the disease and the virus, and how as a community we can mitigate the risks. Thank you again for joining us today, and thanks again to Dr. Schulze.
Well,
Thank you
thank you,
very
Joel,
much.
for the masterful mediation too. And thanks
Thank
for
you.
Charmaine for setting this up. Thank you, Daiichi.
Thank you.
All right, take care. Bye, everyone.
Thank you. Thank
Stay
you.
safe.